We are very much looking forward to supporting you during today's webinar, PAHO's initiative for the elimination of communicable diseases, addressing the social determinants of health to accelerate disease elimination. And I'm now delighted to hand over to Vanessa Scholtens, Director of Communications and Events Management at the Coalition for Operational Research on Neglected Tropical Diseases, to welcome you to today's session. Thank you.
Thank you so much, Debbie. Good morning, good afternoon, and good evening, everyone. It's a pleasure to welcome you to today's Research Links webinar on addressing social determinants of health to accelerate disease elimination. This session is co-hosted by the Pan American Health Organization, PAHO, and the Coalition for Operational and Research on Neglected Tropical Disease, CORE-NTD. And we are honored to have you join us. Again, you are welcome to submit questions for our speakers using the Zoom Q&A feature. Feel free to add your questions throughout the session. There's no need to wait until the designated time for Q&A. Today's topic, the social determinants of health, is crucial to PAHO's mission to eliminate more than 30 communicable diseases in the Americas by 2030. This initiative emphasizes 4 key pillars: integrating health services, enhancing surveillance, addressing social and environmental determinants, and strengthening governance and financing. We'll be exploring tools and approaches to integrate social determinants into programmatic action, featuring experiences across the region. Now, let's take a quick look at our agenda for today. First, we'll have welcome and introductory remarks by Dr. Gary Eichmanns. Then we'll have a presentation on PAHO's Elimination Initiative framework, focusing on addressing social and environmental determinants of health as a key line of action to achieve and sustain disease elimination. Third, we're going to have insights into PAHO's health equity tool. And fourth, a case study from Chile on integrating social determinants into disease and elimination efforts. And finally, a Q&A session with our speakers where we're going to be answering your questions, so stick around for that. To start our session, I am pleased to introduce Dr. Gary Eichmanns, Director of the Department of Social and Environmental Determinants for Health Equity at PAHO, for a few welcome remarks. Dr. Eichmanns.
Thank you. Thank you so very much. It's a real pleasure to welcome you here as the Department Director on Social and Environmental Determinants for Health Equity of the Pan American Health Organization. Very pleased to have this fantastic webinar organized in partnership with several important partners. And I'm sure that you're all going to be very pleased with this interesting webinar. So the elimination efforts is one of the bold proposals of our relatively new PAHO director, Dr. Jarbas Barbosa. Eliminating any disease or any condition is not a simple task. We know that. It requires collaboration between many different actors, not just the Ministry of Health, not just at central level. It really requires an intersectorial and an all-of-society approach. And it's within that context that addressing social determinants of health is a key element for eliminating communicable diseases and conditions. It is essential to make the social determinants of health a core component in these efforts. We know that addressing these determinants will allow us to tackle not only the condition, but those underlying factors that increase vulnerability. And so by addressing those determinants, we enhance the effectiveness and the adaptability of our interventions to better adapt to specific local context and to specific challenges of populations and situations in vulnerability. So the Pan American Health Organization has taken an integrated and an interdepartmental approach to Elimination Initiative. Thank you very much, Marta and colleagues, which focuses on understanding and addressing those mechanisms of vulnerability that affect exposure and the response to communicable diseases. This comprehensive approach enables us to design targeted interventions that will overcome specific barriers, access barriers, ensuring that access and adherence to treatment among vulnerable population becomes a reality. And it also allows to include, for example, health promotion as a key pillar and a focus on primary prevention. For example, access to water and sanitation are critical for eliminating many diseases. And let's also not forget how climate change is affecting and complicating the elimination of disease, for example, by changing mosquito breeding patterns. And all those efforts together are vital for amplifying impact for achieving equitable and sustainable health outcomes. So the Pan American Health Organization has placed health equity as a key element in our work. And this is reflected in this elimination initiative. And by working together between departments, the Department of Social and Environmental Determinants of Health and the leadership of the Department of Communicable Diseases, the Disease Prevention, Control and Elimination, we do not just merely identify vulnerable groups, which is very often a tendency, but we actively look at the underlying mechanisms. We identify them, we try to understand them and to address them. Those underlying mechanisms that create and sustain the vulnerabilities that need to be addressed. And this commitment to equity ensures that our policies and programs for communicable diseases, for communicable disease elimination, are generally responsive to the needs of the populations that we have not reached yet, those populations that we have left behind. The advantages of making this comprehensive approach are clear. It allows us to optimize resources, to make interventions more effective, and to reduce health inequities. By avoiding fragmentation and by designing contextually adapted interventions, we ensure that resources and actions are distributed fairly and effectively, promoting a sustained positive impact across our region. And additionally, collective work at all levels strengthens the development of inclusive and participatory policies. Such policies are crucial for gaining the trust and the active participation of communities. And we know that without an active participation of the community, real engagement, meaningful engagement, we will not have success in our disease elimination program. And it's also working together also is reflected and it will enhance effectiveness of our policies, but also reduce inequalities and ensuring that our efforts to eliminate diseases are equitable and inclusive. But furthermore, we also not just need to work, with the community, but also in an intersectoral manner, in which health plays a role, but not the only role. And it also requires us to focus on working at the various levels of government, with the local level being critical, and of course with other partners that are on the ground and that support those efforts. So before closing, I really want to thank our partners for everyone who has made this webinar possible. And I want to thank all of you who are here with us today, or listening later on YouTube, for your efforts, for the efforts that are being made in the countries, for the progress that you're making. It is only together that we are going to make the difference and that we can move forward to a healthier and a more equitable future for everyone. Thank you so much.
Thank you so much, Dr. Eichmann, for those welcoming words and for your commitment to advancing health equity across the region. It's an honor to have you set the tone for today's discussion for us. I would now like to welcome our first speaker, Dr. Marta Saboya, Senior Advisor for Communicable Diseases Elimination Initiative at PAHO, who will introduce the Elimination Initiative framework. Dr. Saboya.
Thank you, Vanessa. Thank you very much. And good morning, good afternoon, good evening to our participants. Thank you, Dr. Eichmann, for setting the tone for this important webinar on the social determinants and the agenda for the elimination of more than 30 communicable diseases and conditions in the region of the Americas. So now I'm going to present the framework that we have for the elimination of diseases. Let me change here. Okay, I guess that all of you are seeing now my presentation in full presentation mode. So the Elimination Initiative is targeting more than 30 communicable diseases for the elimination in the region of the Americas and related conditions. It is important to highlight that this elimination initiative has been designed based on the rich and long history the region of the Americas has in eliminating diseases. Each one of the bubbles or boxes in this figure are representing a disease that has been eliminated in the region of the Americas, in some cases in the entire region, such is the case of vaccine preventable diseases such as measles, rubella, congenital rubella, neonatal tetanus, or poliomyelitis, and also is highlighting some achievements in this region regarding, for example, neglected tropical diseases. We are one of the regions that had the countries achieving for the very first time in the world the elimination of onchocerciasis, for example. Most recently, Mexico achieved the elimination of human rabies transmitted by dogs. And we also have Mexico who has eliminated trachoma. In some other cases, we have countries that have been able to achieve the elimination of mother-to-child transmission of HIV and syphilis. So it's based on this very long and rich history of elimination of diseases that the Pan American Health Organization presented our member states in 2019, the framework and the policy for a sustainable action for the elimination of communicable diseases and related conditions by 2030. This framework was approved unanimously for all the member states of our organization, and the main components of the elimination initiative is not only the diseases. We know that we have a very strong capacity working on specific programs for the elimination of diseases, but what we are proposing here is to put an additional pair of lenses to accelerate the efforts of the elimination of diseases in the region based on four principal or main lines of action that includes strengthening integrated health services with a focus on primary health care, reinforcing health information systems and surveillance systems, addressing environmental and social determinants of health, and reinforcing governance, stewardship, and finance. And of course, these lines of action are needed to achieve the elimination goals with additional components focusing interventions during the life course and in some cross-cutting and important areas such as human rights, focusing on populations living in vulnerable conditions, and gender equality. So this is the framework. It doesn't mean that we are going to leave behind the specific disease approaches. The framework is proposing that we continue doing that, but now focusing the attention on these cross-cutting areas that are common and are needed to accelerate the efforts country by country and in the region to achieve the elimination targets. This is the current list of the 30 plus diseases and conditions that we have included in the elimination initiative. They are divided into 4 groups. The first group has the list of diseases in which we know that we have tools, strategies to achieve the elimination targets, and that is technically and scientifically feasible to achieve those targets. We have a combination here of neglected tropical diseases, vaccine preventable diseases, sexual transmitted infections. We have tuberculosis, for example, or also we have cervical cancer. So we have a variety of diseases in this first group in which we know this region can accelerate the efforts to achieve the elimination targets. In the case of the second group, we have 2 environmental risks: open defecation and the use of polluting fuels in households that are targeted for elimination in the region of the Americas. The third group is an important group in which the entire region has achieved the elimination targets and is key to maintain and protect those achievements through the implementation of specific actions, such as the case of vaccination, and strengthen surveillance to detect any reemergence and respond immediately to those risks. And the fourth group has two diseases that has been targeted for eradication globally, in which this region needs to achieve the interruption of transmission to contribute to the eradication goal: foot and mouth disease and YOS. So this is the group of diseases. This is a list that is active. We are reviewing the information and the evidence for other diseases that might be included in the list for the elimination in the region by 2010. Now I'm going to focus the attention on one of the 4 lines of action. So as Vanessa and I mentioned in the beginning of this webinar, there are 4 lines of action that are the core of the elimination initiative. The third one is addressing social and environmental determinants of health. That is key for us because, as Dr. Ekmans mentioned, if we don't include the approach of those social and environmental determinants, is going to be harder to achieve the elimination goals in the entire region. And when we are talking about social and economic context, it's because this is key if we want, first, to accelerate the achievements, and 2, sustain the achievement and improve the quality of life of the population. So the elimination initiative is not only eliminating diseases, it's improving the life of millions of people across the region. So all of us know that communicable diseases are intimately related to this list of social and context and economic context determinants: low income, low education, insufficient or in sometimes absence of to services such as health, education, water, sanitation. And we have an additional problems in some specific populations such as discrimination and stigmatization. When we put together these social determinants of health with the individual and community characteristics, especially the individual characteristics such as physical and biological factors such as age, exposure to certain conditions of factors, or even genetics, this combination makes the endemicity of communicable diseases harder to reduce, and the populations are going to be in a long term of impacts and damages caused by these diseases. This is the rationale behind how we are seeing the approach of the social determinants to accelerate the elimination of diseases. And when we are talking about why we are including the social determinants component in the elimination of diseases, is because we want to work on the root causes of these diseases. It's not only to implement the medical interventions, but really to achieve long-lasting impacts in those communities with equity focus. So Dr. Ekmans mentioned those components in the opening remarks, and that is the key and the core for us if we really want to achieve the elimination goals. We are interested in reducing the burden of diseases, but that means that if we want to do that, we need to have communities that are resilient and that they have better living conditions, and that also we're going to impact and enhance health systems efficiency so they can focus the attention on prevention and early interventions. So this is the list of the 30 plus diseases for which our countries in the Americas haven't achieved yet the elimination goals. As you see, we have a lot of diseases that are still endemic and affecting populations in several countries of our region. This is the hard job that we have to accelerate the elimination goals. But if I zoom in the group of neglected infectious diseases and zoonotic diseases, we can see that not in all countries of the Americas we have populations affected by all these diseases. We have leprosy, for example. Leprosy is affecting several countries in our region, but it doesn't mean that this disease is affecting the entire population in those countries. But if we change the attention to trachoma, for example, we only have trachoma in 4 countries. So understanding what is happening behind this distribution of diseases in the region, and not only at the national level, but at the subnational level, is key for us to accelerate the elimination goals. If we look into what is happening with leprosy, and this graph is showing the number of autochthonous cases of leprosy across the region according to the most updated information that we have. We have the big majority of the cases occurring in Brazil, but suddenly from almost 20,000 cases in Brazil, we have a group of countries that have between 100 and 400 cases, autochthonous cases of leprosy per year. What are the differences in those countries? Where are those populations that are affected by this disease, and what are the conditions in which they are living and the determinants that made them be affected by leprosy? But also, we have a group of countries that are reporting annually between 10 and less than 100 leprosy cases per year. Probably they have these groups of population in very specific areas within the country, and in some cases it's very difficult to achieve them through the regular health system. And then we have a group of countries that report less than 10 new autochthonous cases of leprosy per year. They are probably very close to the elimination goal, but we need to differentiate the interventions in each one of the countries to understand what are the root causes of having leprosy as a disease that is still affecting populations, even though that we have tools to diagnose and treat these populations. And exactly the same for other conditions. We are seeing here the percentage of population that practices open defecation in the region of the Americas. And you can see that the percentages are very different among the countries. What are those differences? What are those populations that are still practicing open defecation in the region of the Americas, and why? So understanding what is happening behind these figures on the number of cases or percentages of populations affected by X disease or having this kind of risk practices is key if we really want to accelerate the elimination of these diseases and conditions. Dr. Ekmans mentioned that climate change and environmental determinants are key for some diseases, specifically for vector-borne diseases. And this is the case of Chagas. I'm showing you the where do we have Chagas at the first national level, and we are monitoring the indicator that includes the elimination of the transmission of Chagas disease by any vector. And very few countries have achieved the interruption of transmission by all vectors in the entire country, but some of them have achieved that goal only in some of the subnational areas. Why? What are the differences there? What is making some of them achieving the elimination goal at the subnational level, but not in other areas within the same country? And this is very related to social and environmental determinants of health. And we also need to look into what is happening with gender equity and cultural diversity. And this map is showing you where do we have onchocercasis foci in the region of the Americas. And the last foci focus that we have for onchocercasis is between Brazil and Venezuela in a very remote area in the Amazon jungle, affecting indigenous populations that are living under very hard and difficult conditions that has made difficult to accelerate the elimination in the last focus that we have in the region of the Americas. So we need to understand what are those characteristics and how we can adapt the response of the different programs, and not only from health sector, but also from different sectors to accelerate the elimination of onco. And this map is showing you the places in which we still have trachoma, an elected tropical disease that has been included in the elimination initiative with the elimination target, and where do we have some areas that still have populations affected by this disease. But in other areas, we have been able to work with countries to reduce that prevalence of trachoma. So when we are talking about practical applications of social determinants of health to accelerate the elimination of communicable diseases, we are talking about things that are not only related to medical interventions. So if we want to accelerate the elimination of tuberculosis, for example, in urban slums, we need to talk about how we are going to improve access to health and safe houses, nutrition, that are key components to eliminate tuberculosis in the region of the Americas. If we are talking the elimination of neglected tropical diseases, we need to move forward and beyond to the implementation of preventive chemotherapy, for example, and how we move towards the community education, economic support initiatives to improve quality of life, living conditions of those populations living in those remote rural communities, and access to water, sanitation, and hygiene that are highly related to the endemicity of neglected tropical diseases. We also have HIV and AIDS as part of the list of diseases for which we want to achieve the elimination as a public health problem. But we need to include in those interventions actions that are related to education, mental health support, and access to job opportunities, for example, to improve lives and reduce the burden of diseases of those communities. So we want to make social determinants the core component or one of the core components of the disease elimination initiative. And there are key strategies that we need to accelerate with countries. First of all, we need to understand the effect of policies on health outcomes across the social determinants of health. We need to accelerate the meaningful community engagement in planning, implementing, and monitoring actions. And we need to accelerate the cross-sectoral collaboration if we really want to impact on the root causes of the communicable diseases. We want to continue working on the disease control elimination actions. That is needed. We need the specialty, we need the experts, we need the specific interventions. However, we need to combine that very soon and in a more accelerated pace with community and social determinants of health integration if we really want to have holistic health outcomes and improve the living conditions of the affected communities. I would like to invite all of you to review our Elimination Initiative Regional Data Portal that has very good information about the elimination targets for the 30 plus diseases. And finally, as I started my presentation with the past and the history of the elimination of diseases in the region of the Americas, this is the future based on the best information that we have at the Pan American Health Organization. Each one of the bubbles is showing you a disease and the list of countries in which we think we can achieve the elimination targets from now and before 2030 under the Elimination Initiative. So thank you very much. And Vanessa, back to you.
Thank you so much, Dr. Saboya, for that overview of the Elimination Initiative. The goal of eliminating more than 30 communicable diseases by 2030 is ambitious, but as you've shown us, it is grounded in a comprehensive and integrated approach. Next, we will learn about a powerful tool for ensuring health equity across elimination efforts. Please welcome Dr. Oriel Solar Ormozabal, Head of the Health Promotion and Social Determinants Unit at PAHO. Welcome.
Muchas gracias, Vanessa. Voy a compartir pantalla.
Thank you so much, Vanessa. I'm going to share my screen.
Ok, bueno, siguiendo,
Okay,
digamos,
well, let's continue.
lo señalado de la importancia
We
que
have
ya
already
se
mentioned the
ha
importance
escrito sobre el
that has already
abordaje
been
de
described about the
determinantes
approach
sociales y
of using
condiciones
social
sociales para
determinants and social
poder acelerar
conditions
la
to be able
sección de
to
cualquier
accelerate
enfermedades.
the actions
Voy
for
a
disease
tratar de
elimination.
centrarme
So I'm going to
en
try
esos
to
ámbitos
center
y
on
compartir
these
con ustedes
topics
algunas
and to
herramientas
share
en
with you
breve
some
exposición, ¿no?
tools during my
Un
brief
principio clave
presentation. A
que
very
en
key
la
principle
organización,
here
¿cierto?, se ha
in
planteado
the
y que es
organization that has been
un
proposed,
principio presente
and is a
junto,
basic
¿cierto?, de los
principle.
países y las regiones.
It is a
Es
principle that we
que cuando
share in this
abordamos
group
los
of
temas de
countries and the
ácido,
region.
sin duda,
When we
cuando
talk
hablamos de
about
éxito
anything
de
that
un
has to do
programa,
with health, and when we
en
talk
este
about
caso
the
de
success of a
eliminación
program,
de
in
la
this
enfermedad
case,
infecciosa,
disease
decimos
elimination,
que es exitoso solo si
we
éste lo es
insist
para un
that
grupo
it is
social
successful
aventajado como lo es para el grupo
if it
más
is successful
desventajado.
for both
Y
a
ahí ponemos
social
al
advantage
centro la
group and a
equidad
disadvantaged
como uno de los
social group.
objetivos
And
y las metas
equity is
que
one of
tenemos
the
que tener
objectives. It's
presente
one
en
of
el
the goals
conjunto de
that we
nuestro
always
programa,
have to keep in
en
mind as part
asegurar
of the
que
program,
aquellos grupos
to
en
make sure
situación
that
de mayor
those groups
vulnerabilidad
that have a
efectivamente
higher
accedan a los
vulnerability
recursos, a los
situation,
servicios
that they
y a una
have the
mejor
same
calidad de vida y
access to
bienestar.
resources
En
and
ese
services and
contexto,
better
¿cierto?,
quality of life and
cuando
well-being. And in
analizamos
this
ya
context, when we
antiguo, ¿cierto?, de
analyze,
algunos
and this
autores,
is old, of
cuando
course,
referimos
and
la causa de los
we
casos
talk about
de
the,
por qué una
the, the
persona tiene este
cause.
problema de salud y
Why
enfermedad,
is this person
hacemos
suffering
la
from this health
diferencia
problem?
en eso que nos
Then
referimos a la causa de
we
las causas,
establish
¿cierto?, que
the
refería Rose
difference
hace
here. We talk
muchos
about the
años.
cause of the
¿Por
cause.
qué esta
This is something that
población o
we've been
grupo
talking about for
social o
years. Why
territorio
is this
tiene
population or
mayores
social group
problemas
or
de salud que otros?
territory experiencing
Que
bigger
Marta
or
nos
more
reflejaba,
problems,
¿cierto?,
health
con
problems than
respecto a
others?
cómo se presentan
That
las
is what we were
enfermedades, la
talking about. We
prevalencia
are talking about
y la
how
incidencia
disease
de ellas en las
presents, what the
regiones,
prevalence
y
is,
cómo
and
al interior
incidence
de
in
los
different
países se
regions,
concentra
and
en algunos
how in the
territorios
interior
o en
of the
algunas
countries
condiciones
you see a concentration
específicas,
in some
¿cierto?,
of
que
the
hacen
territories.
que
There are
esta
some
situación
specific
sea
conditions that
de
make
mayor
this
permanencia,
situation
¿cierto?, de
to be more
incremento en el
permanent
último tiempo.
or to
En este
affect them
marco,
more.
¿cierto?, cuando nos
And
referimos a aquello,
within this
nos estamos
framework, when
planteando
we refer
determinantes
to
sociales de
this,
la salud,
and when we're talking
esas
about social
condiciones que
determinants of
hacen que
health,
se
those
concentren determinados
conditions
grupos sociales o
that cause for
territorios,
these
tiene una
particular
explicación,
social
tiene
groups
una base
to be
basado en
more
el
vulnerable.
contexto en
And
el
this
cual
has an
se insertan
explanation, and
esos
it is
problemas
based on the
sanitarios.
context in
Y
which
lo
this
primero
health
que quiero
problem is
rescatar en este
based. So,
sentido
the first
es
thing
que
that I
cuando
would like to
miramos
mention in
el
this regard
proceso
is
de
that when
salud
we
y
look at
enfermedad,
the
sin
process,
duda
health
vemos que los
and
accesos a los servicios
and
muchas
disease,
veces nos
we
concentramos en
undoubtedly
ofrecer
see that access to
habitualmente,
services,
¿cierto?,
which
lo
is something that we
mismo,
need to
aquellos
concentrate
que
on.
utilizan los servicios
Normally, we look at who
y por lo
uses health
tanto,
services, and
principalmente aquellos que tienen la
therefore,
capacidad de
we're
contactar los
talking mainly
servicios
about those people
para
that
mirar
do
esta
have the
continuidad de
ability
la
to
atención,
contact
¿cierto?, y
services,
el
to
vínculo
get
con los
services,
servicios.
to look at
Pero sin duda
continuity
tenemos
of
una parte
care and link to
importante
services.
que tiene
But
que
no
ver con
doubt
cómo
there's
esas
something really
condiciones
important,
sociales
and the social
influyen sobre la
conditions
necesidad de la
influence
atención,
the need for
influyen cómo
care,
se expresa esa necesidad de
influence
atención en
how
una
this
demanda
need for care
asistencial
expresses itself,
e influye
in
cómo se
health
percibe un
demand
determinado
and
riesgo
in
o un
perception,
problema de
how
salud
you
y
perceive
enfermedad, y en
a
este caso
certain risk,
eliminación.
health risk.
Entonces, lo primero
And
que queremos reforzar es que
elimination
los
is what we're
determinantes
talking about
sociales
here too. So the first thing
influyen
that we
sobre
need
la
to
expresión de
reinforce is that
necesidad de
social
salud
determinants influence the
y también
expression of
influyen, ¿cierto?,
need for
sobre la
care,
demanda de los
and it also
servicios y la
influences
percepción de
the
riesgo.
demand for services and the
En ese
perception of risk.
sentido,
So in
cuando
this
miramos
regard,
otros
when we
ámbitos
look at
de
other
cómo
areas, how
determinantes sociales está
certain
influyendo en
social
especial en los
determinants are
resultados sanitarios,
influencing
nos
the
encontramos
work,
también
the
de que
healthcare
aquellas
results and
intervenciones
outcomes.
que sabemos que
We
son
also
de
find
enorme
that those
eficacia con
interventions that we
respecto a
know
lo
to
que
be effective,
buscamos, con respecto a lo
because
que
of what we're
tenemos en
trying
evidencia
to
en literatura,
do, because we have the
nos
evidence in
encontramos que la
literature that they
implementación
do
de ella en
work, but
ciertos
we see
contextos
is
con
that
respecto a brechas
implementing these
en
principles
materia de ingresos,
in certain
¿cierto?,
under certain
brechas en materia
conditions
de nivel
shows
educativo,
an income
brechas
gap.
en materia
There
de
are
con
income
respecto a
gaps,
vivencias, ¿no es
educational
cierto?, de
level
situaciones de
gaps. There are
discriminación por razones
gaps in terms of
étnicas, por razones,
experience,
¿cierto?,
exclusion,
diversidad de género, por los procesos
discrimination,
migratorios
sometimes
que viven ciertos grupos y
you
territorios
know,
en nuestra región,
gender
se
diversity, migratory
incrementan las
processes.
brechas en materia de
So
equidad,
there are
y esa
huge
brecha de
equity
equidad con
gaps
respecto al
that
tema de los
exist.
resultados
And
sanitarios
we
se
see that
expresan también
this
en
is the issue when you're looking at health outcomes, and they're expressing how people are able to reach services and how we're able to reach the populations in terms of access, early diagnosis, access to providers, access to medication, all of it is affected. And the second element is that if we do not intervene in terms of the social determinants of health and equity, it also affects effectiveness and therefore the effectiveness of the programs that we're that we're promoting. So at the same time, when we look again at the social determinants and the social conditions, and we look at the social groups or the territories where we're having these interventions, we know that there is a heterogeneity and different reality in each region, and we need to adapt the interventions to these groups that live in vulnerable conditions. So it's not about doing the same thing or more frequently, but the same thing. We need to modify what we're doing. We need to change the processes. We need to know the groups. We need to know the details, the mechanisms that are generating the exclusion, that are generating inequity, and that have a direct effect in the effectiveness of the programs. In that regard, we highlight that we understand the equity of access to services, what we need to work on. And what we were saying at the beginning, when you have equality of needs, you have to treat people the same way, regardless of their ability to pay, gender, race, or where they live. And that is what we need to organize ourselves. And this is different when we say that we recognize that there are different needs in the different groups and you have to treat them differently. And that is what we were talking about, vertical equity, which means acknowledging that there are differences and we need to have different interventions that respond to those contexts. And we are talking specifically about the social determinants of health in which the territories are inserted and in which people and communities live. Within this framework, we try to advance in how we look at this within the framework of infectious disease and our strategy for elimination. We had a collaboration and we want to strengthen better results. And we know as a fact, or for a fact, that in terms of results, immediate results, we know what conditions we're working in, we know what the psychosocial factors are, we recognize the comorbidities, we recognize the reality of the migration process and how this influences these matters. We know the importance of climate change, but we see that behind that, there are certain mechanisms and certain structural aspects that really tell you how we're going to have better or worse results in this area through what's economic, social deprivation, social protection. There are groups that are minority groups that don't have the political incidence or the political power. There are the issues of overcrowding, discrimination, distance. So a lot of the things that were presented in the prior presentation. And that intersect with issues of inequality in terms of gender, race, social class, and it's another element in the concept that we have today in the region. So what should we do differently in our work so that we advance equity? How do we totally integrate social determination in our job? Is it possible to do this from our programs in an integrated manner and from the territory itself? And within this framework, we know that we always have doubts, we always have questions. On the one hand, this is complex. This has to do with other sectors. This is not health issue itself, that we have limited time, there's lack of knowledge, and also in in terms of the personnel, the health personnel doesn't really know what concrete actions they need to take. They don't really know what resources are available in their community when we're talking about social participation in terms of times and conditions. Health personnel sometimes is overwhelmed. They don't have the time. They have a lot of new tasks to face, and there's always difficulties. And the work between the different sectors is one of the obstacles. And in this context, we propose that it is necessary to promote having a more comprehensive approach to addressing inequity. That would be something that would serve us in the first stage. Maybe to explore, to raise awareness, to reflect, and also to give options of various paths. Because the realities are not the same, the context is diverse, and this is a tool that arises from this quick analysis. We had to go through a process of validation. It's under construction right now, and it allows us to understand the inclusion status, the gaps that exist, and to plan on the strategies. But it is centered on how, not just to know how, the magnitude of inequality or recognizing the sort of social groups and territories and all the relevant issues. It has to be centered on how this equity approach will lead to equity. It shouldn't be just aspirational. This should be translated into content and design and implementation. So this tool has 8 components. It has, our approach. We say that the equity approach is how to prioritize this objective of achieving equity. How do you prioritize the population that is objective or our target population, and how this population that lives in a situation of vulnerability not only has limited attributes, but also in social context. So how do you look at the barriers? How do you look at the obstacles? Not just the obstacles to accessing services, also obstacles that have to do with demand and everything that has to do with the underlying social conditions. So the interventions the program is proposing is considering this intersectoral work. And that would be a fundamental access, social participation in this process of for these interventions, and also for program formulation and how the mechanisms for monitoring and evaluation you have to monitor how to reduce inequalities and also see the impact of other policies beyond the health sector on these programs. For many people, anything that has to do with housing, transportation, everything that has to do with social policies, all of this is fundamental for the success of these health programs. And as part of this process, and you have these 8 components, we have been validating some of this. And here, this gives you a general idea. We are right now in the preliminary phase. Each one of these domains is present as part of some programs. We have the cardiovascular program, we have the SESEP program, which is a comprehensive approach to comorbidities, focused on older adults, and is more centered on the vulnerability situations. And for some areas, this has limitations, and certainly in several of the axes that were pointed out. This is just a first approach, so to speak. It's a simple tool that allows us to become more aware, to open the door to the teams with respect to the different needs and vulnerability, and to take a comprehensive view of what's going on. And this allows for some teams that, for some of the teams, this may be an area of priority work, and for some of them, it may be a different one, and you have to concentrate on the conditions or the context in the different countries. This takes us to a different tool, which is called Innova. It is a tool that has existed for a few years. It comes from a Ministry of Health, in this case, Chile, and it responds to this idea of trying to operationalize the issue of social determinants within the work. Therefore, it was not an academic exercise. It was a need, an institutional need for service management. It's a tool that doesn't need to tell you what to do, but it lets you work with the teams themselves, and it focuses on the challenges. It does an analysis of how these groups are being left behind and what are the solutions that are feasible that you could implement. And there are several tools that are part of Innova. Innova has 8 steps, and each process is unique in the country. And these 8 steps are written down right here. One has to do with a baseline construction for the program, for the strategy, a plan to be developed. Then following that is centered on trying to understand why the program expects to produce results. And that's why we talk about trying to build the theory, program theory, not just the theory of the program that is not just the objective or the goal, but what's behind it that is going to make it happen, is going to make these goals a reality. After that, we try to see who the groups are, the territories, the social groups, who are the people that are being left out of the program. Even though it could be defined as people that could be part of the program. And then starting there, we analyze what barriers and facilitating factors exist for the different social groups that have been identified that were left behind. And perhaps you see these groups in certain areas of the strategy, maybe in certain actions are part of the program, but you need to identify these groups. And with this, we try to identify why are these inequities generated. There are more specific issues that are specific to each health program. And with that, we also enter a step in how to understand this action, that integrates different sectors and social participation in the program. And we try to look at the issue in depth. And we try to look at the recommendations, what kind of changes we need to make in the program. And we want to change that initial theory of the program, and the formulation that we propose states what actions we need to implement, what changes have to be implemented, what are the new interventions, what are the new intersectorial actions that need to be implemented, how to strengthen social participation to achieve certain results. And with that, we have to define how to monitor, how to evaluate that process, the process of change, so that we can see results and we can make attribution of where the changes started. What is it that caused the change in terms of the results that we propose to achieve? So we have the 8 steps. This tells you what it is, how it works. Then there's the second stage that that sees exactly what worked, and to decide what groups are still left behind. Are there still groups that are left behind? Are there territories that have been exploited? Are there barriers? Do we still have barriers? And that tells us that the program perhaps is not working the way it was intended to work. And then we go into the third phase, is steps 5 and 6, which is to identify the mechanisms that generate these inequities and to be able to face them and do something about it. And we do that by understanding what are the mechanisms that generate this inequality and understand how to work and what the social participation is. And with this, we go into the last stage, which is to the proposal for change and improvement, and define the systems and the monitoring systems. And in this sense, we have some general examples. For instance, perinatal health, for instance, addiction and mothers. We did an analysis with TB, for instance, and we looked at discrimination and stigma and how this marks certain results in these programs, especially in the migration process, or how childhood obesity and physical activity, those those are programs that we focused on, and we see how the population strategy was something that we needed to look at again. And when we look, for instance, at respiratory illnesses in older people, we decided to reorientate services as one of the goals. And this is just a general idea. I think these elements help you look at how some of these tools may be useful. You, of course, need to adapt them to the context of each country, but they can help us integrate concretely the social determinants of health within our strategy plans and programs. Thank you.
Thank you for introducing the health equity tool, Dr. Omarzabal. This tool is definitely essential for promoting fairness and inclusivity in the disease elimination efforts, aligning directly with the PAHO's goal of health for all. Now, let's move to our next presentation from Chile on integrating social determinants into programmatic actions. Please welcome Dr. Gina Pereira, National Technical Cooperation Expert from the Department of National Agency of Cancer Prevention and Control from the Ministry of Health of Chile. Welcome.
Buenos días, buenas tardes, buenas noches a todos quienes nos acompañan. Muchas gracias, Vanessa, por la
Good morning, good afternoon, good evening to everyone, and thank you very much for organizing this very, very important webinar.
Ahí se está compartiendo la pantalla.
And just give me 1 second here. I want to share this with you. I am representing a group of professionals in up and down Chile, some of the transnational groups as well. I will be talking about the context of the social reform that we're having in Chile. How will we integrate our plans in the national areas? And we are redesigning the cervical uterus cancer programs. We'll be speaking about looking at other focuses that we've had in order to be able to eliminate and redesign the cervical cancer. Explain to you, how are we made up? We have different cancers, the breast and cervical uterine, and how we have made this the center of our work. I will be sharing with you some of the national initiatives, the specific a checklist and our steps and program theory. I was telling you, we have 3 members. We have this in the national areas. We are divided into 6 regions in Chile. We have our members here, 14 members. We have the 2 areas in Chile that participate in cervical cancer node. These are areas or regions in Chile that are located at the extreme of the extreme easterly area. Now, westerly, pardon. We have shared this with different groups. How have we redesigned the different programs that we have with breast cancer and cervical uterine cancer? And we wanted to learn what are the main concerns that we have in redesigning both programs, taking into account that these are programs that do not have exactly the same population. We also had other limitations. The other limitations was to redesign the technical guidance and programs. They're not updated, and unfortunately, this has opened the door for us to turn back to try to learn what are some of the health interventions that were taken into account and find out, were they technical breaks that we had, or do we have any other forms of interferences? We also have science. Science does have intervention. Now, it does evolve, and likewise, they were not contained in these programs. And we had a series of analysis. What did we take into account? We have the technical guidance or the basic document, or do we have other areas? Finally, we ended this first phase, this first workshop, by generating solution proposals. As you can see with Dr. Solar, what we did was analyze the different areas: equity, monitoring, evaluation. We approached the different health systems and worked with either the breast cancer or cervical uterus cancer. And we had the correlations. Was this incipient? Is it promising? Is it developing? And we find that we are located exactly in these points where there's an intersection with both programs. Yet, and we were not eliminating one of them. These are the points that we reached and highlighting the different areas impacted by gender and social, economic, and cultural diversity. And up and down the workshops, one of the factors that we found was analyzing the different steps that this tool handles that. We had to decide, and the decision was which of the 2 programs were we going to work: breast cancer or the ones that we thought about before, understanding these are populations that do not have any matching points. And we finally did have a very rich discussion. We had certain visions deciding that the cervical uterine cancer has areas of opportunities. We see this in the right-hand side. There's different types of infections, the vectors like the papilloma virus, human papilloma virus. We also have need to work with the tools that will allow us to work with this disease, which is why we were talking and we were hearing about how to eliminate the communicable diseases, including this. Now, alongside these areas linked to the causing agent, we have available health technology for those different areas, so we can have the matrix that we need. Now, eliminating the cervical uterine cancer is a world target. It's covered with coverage, treatment, and the matrix design. We selected this type of cancer because of the opportunities and due to the needs to try to avoid new cases and be able to eradicate this disease. Previously, we do know what are some of the agents. We know that intervention and a disease, a long data where most people will acquire this infection, and a majority in this population will naturally eliminate the infection, yet we have a small minority that make the disease persistent and there will be a progression from low grade to high grade of the lesions that we have. That is why the intervention in this program is grouped in immunization, the selecting and treatment. We have different initiatives. In Chile, we see how it's been helping, approaching, working with this type. In the 70s, we had in the 60s, we had a pilot program with PAHO and with Chile Health Ministry. Then we developed the program, and throughout the different years, we developed the programs, the guidance, technical guidance. 2004, we created a transversal program for the different groups. And one of the first diseases that we incorporated was the cervical uterine cancer in something called the Explicit Guarantees in Health. This is GES program. Likewise, understand what most of what we were learning through the screening machine was helping. We also made important strides in the approach. By 2019, we included men. And since 2019 and slowly we've been including different tests so we can eradicate the human papilloma virus. Now, these strides makes us think about certain suppositions to understand that, yes, this is a success. We have programs, we have educational workshops, people become more sensitive, and they will be able to modify their areas of expectations so we can become more sensitive. The other area of beliefs or the suppositions is to be able to work with HIV. Now, although there's no correlation, we will be working with this. And those that are not accepting this, we will design a strategy to go look for these children so they are not left behind. Now, we also have with women who will be going to their control appointments. Then we have the second level of prevention. Make sure we have the proper level of exams, that people that are asking for these types of exams, that they are provided, and by doing so, we will have the proper detection. And finally, we have the third level of attention, availability of the medical attention, availability to work with the pre-invasive lesions. Know that women will be following treatment, follow-up. Treatment will be efficient, and these treatments are being standardized and guaranteed by law. Now, with all of these, with this background, of course, we need need to think about things. If we know about the interventions, then even if we have a health problem, we understand its pertinence, and we understand that this type of cancer is the fourth most prevalent incidence rate, is adjusted per 6,000 women, and represents 1,600 new cases with and about 13,000 people with people or women that will have the early onset of the disease.
This is a lot more dramatic. There's a comparison between survival, and we see that cervical cancer is completely preventable. It exists. It has a long history, as it was shown before, and the survival is way below what happens with breast cancer. This is an example. When you do a survival analysis at 5 years, you do this analysis and you see that 63% versus almost 80% in breast cancer and mortality, obviously. It's a mortality that is quite important, and it represents it's in the 7th place in mortality. And we know that about 600, 700 women die from cervical cancer every year. So I'm going to show you now how we redesigned the program. And Dr. Solano showed very well what the 8 steps are of this innovative strategy. And I want to show you now the first 2 steps. The rest of the steps, we have analyzed this internally in our team, as I mentioned earlier, but I would like to concentrate in these 2 steps for the purpose of this presentation. And this is a vision and overview of the questions on the checklist. We have questions 1, question 4. We review the purposes, objectives, goals, and results, and expected results of our cervical cancer program. And in questions 5 and 7, we have the main areas of intervention, the context, and who is in charge of implementing this intervention. Steps 8 through 10, we review the participation, action, intersectorial actions, monitoring, evaluation, and which are some of the initial conclusions of this health program. I do not want to say too much more about this slide. I just wanted to show you how in these different steps on the list, we can identify the purpose, the objectives, and those that have been defined by the program. And for instance, those that do not have a very objective or specific purpose in terms of equity. And we do have, for instance, mortality, but it doesn't necessarily, morbidity and mortality are there, but there is no specific mention of the equity component. And when we interview, when we do the needs assessment, we realize that there are no instances of participatory evaluation, for instance, and for instance, for the development of a clinical practice, there is no mandate by law to do this kind of review. We work with all patients, but we are not required to work differently with certain groups of patients. So what we want to do is improve equity and also to carry out monitoring and evaluation of its effect. And on the other hand, in the field of intersectorial work, we were able to realize that in certain areas, for instance, social protection, planning, work, housing, and things like that, there is no intersectorial work going on. In terms of the educational work that we're doing, we have a coordination with some programs, for instance, the vaccination programs, and there is some intersectorial work in that area. We also identify some promising areas of work. For instance, with the Ministry of the Interior, we're working with Border Patrol and with the Ministry of Women and Gender Equity, and something that is has partially been done and could present some promise in the future. We are trying to develop support programs, and we are trying to gear those programs towards the cervical cancer program. And lastly, when we talk about the challenges in terms of equity and social determinants of health, it is important to point out that there is no clear approach. And there is no clear approach for certain clearly identified population. For instance, gender diverse populations, migrant migrant populations, indigenous populations, women who are caregivers, the homeless, or women who live with HIV. Those people have different needs, and therefore we're not really looking at them. And if we're not looking at them, it is because unfortunately they're being left behind, as we saw in the presentations that preceded me. And step number 2 has to do with the theories that support the program. It's also a general overview of some of the activities that we perform, for instance, conceptualizing the problem, and also finding the solution to, we built a diagram. I'm going to show that to you in a minute, and write summaries and see if there are social determinants that exist that have been identified, and this equity approach and how to use it. So in this step, what we discuss as part of the team is what is the space of the problem and what is the solution, and what is the general theory of the program, and how these considerations affect the different health interventions that I'm going to share with you. This is the diagram that we worked on. It is a diagram that tries to conceptualize the different activities, the different steps that are organized by health intervention for promotion and for primary and secondary prevention or tertiary prevention. And it shows that there are certain final outcomes that have to do with the reduction of morbidity and mortality. And for instance, the effects of early diagnosis and improving survival. And for instance, what are the activities, the specific actions in terms of education or awareness, sensitization, and things like that. And we see that promotion strategies exist in certain areas, and also to provide, for instance, spaces for individual and group counseling is very important to make people more aware of what the risk factors are. And for instance, counseling for anti-smoking activities and plans at the level of the community, at the regional level, and primary prevention is what you have listed here. And for instance, primary care, this is what we have in Chile. Then the gynecological control checkups in Chile, and that is what we try to use to reduce mortality and morbidity. And there are, in those spaces, there are certain screening tests that are offered as the pap smear or the human papillomavirus testing, and of course, school vaccination and for children during their school years. And the secondary prevention, we have all these screening tests, the ones that we just mentioned. We have them here according to how, you know, the positive responses are. And tertiary prevention, we identify what are the activities that we need to perform, the certain treatments that we need to offer. And this is divided or detailed and how the access to treatment exists. After the diagnosis, what happens after diagnosis? Then you go to adjuvant therapy and the different therapeutic alternatives. And then following that, everybody that has received a cervical cancer diagnosis go to the control activities after their treatment. When we analyze this and we prepare this diagram, then this helps us see that there is a very important space where you see that some subpopulations do not have access to these strategies, or if the strategies are there, I mean, they're not available for everybody. For instance, counseling and things like that. But there is a population that has been identified previously that does not have access, for instance, to counseling, does not have access to the screening tests, so that you can, for instance, identify the pre-invasive lesions so that cervical cancer doesn't happen. And therefore, integrating the social determinants of health in this formulation has to be something that is part of the programs, and we think this is an opportunity to analyze and review the causes of health inequity. And this is all very relevant, and the intersectoriality has to help us develop these approaches so that we can integrate all these people, the people that have not been reached by the programs yet. And this program is going to help us reach this. We're going to have this program so that we can access these people, and it's going to strengthen the programs with the population view. Thank you.
Thank you so much, Dr. Pereira, for sharing Chile's innovative experience. I think this case study highlights how prioritizing social determinants can drive impactful changes in health outcomes. It is really inspiring to see real-world applications like this in action. Now, we will transition into our Q&A. I would like to invite all of our speakers and panelists to come back on camera so we can address the questions from our webinar participants. While I'll give some time for everyone to come back on camera, but I want to thank everyone who submitted questions so far. Please remember, we want to hear from you, our webinar participants. Let us know what you thought about the presentations. Send us your questions, and I will be reviewing them throughout, and we'll ask them to our panelists. I will start, let's see, with a question for Dr. Oriel. We have a question in the box saying, "Good morning. How can we have access to the health equity tool to address social determinants?" Over to you.
Thank you. Sí, tenemos las dos herramientas que presenté. La primera, el Health Equity Tool, ¿cierto? Está en proceso de
The two
validación.
tools that I presented to you is right now undergoing the process of evaluation. We expect for beginning of next year, it will be available for the group of nations. We are right now in the process of internal evaluation and also with some of the countries in which we have shared some of the resources so they can help us validate and also coordinate the work. And we also want to do some elimination work. That's why we want to work in collaboration. With the respect to the Innova tool, which is the one that requires more time for the evaluation, it has 8 steps. There is a number of publications at the WHO page. It's in English, it's in Spanish. And also as a team, we also, lend our support for the implementation and for supporting the implementation of this tool. Thank you.
Thank you, Dr. Riel. I think next we have a question for Dr. Marta Saboya. And the question is, how are countries working towards addressing social determinants of health to eliminate several communicable diseases under the Elimination Initiative? Over to you.
Gracias, Vanessa. Thank you, Vanessa, for the question. So we have, since the launch of the Elimination Initiative, countries have been working at the national level to put together integrated roadmaps targeting the elimination of the diseases that are endemic in those countries. And in some cases, and I will use the example of Brazil, in which they identify 11 diseases targeted for elimination, including neglected tropical diseases, tuberculosis, HIV, malaria also. But they put together 14 ministers that are related to the work to accelerate the elimination of communicable diseases. So the way in which Brazil is looking into the elimination of diseases is from the determination of the diseases based on social determinants. So the national plan in Brazil for the elimination of diseases is the elimination of diseases that are socially determined, based on the hypothesis that these diseases are occurring and continue affecting populations because we haven't been able to attack the root causes of those diseases. But the root causes of those diseases can be affected only if we have an intersectoral collaboration and interventions that are not depending only on the Minister of Health. And Oriele mentioned that. One of the challenges that we are seeing across the region is that from the health sector perspective is that this is complex, this is difficult, this needs time. We need to work with many people outside of the Minister of Health. So we want to continue doing the same that we have done for decades to accelerate the elimination of diseases. So now that we are working under the umbrella of the Elimination Initiative, we are moving forward this group collaborations and synergies. Even within the ministries of health, there are departments or sections or groups that are working on the determinants of health. But sometimes under the same Ministry of Health, we don't have this dialogue, coordination, and synergies with those groups that have the experience of working with other sectors. So that's the first synergy and collaboration that we have to move forward. And that's the first step that we are working from the Pan American Health Organization with the countries in the region of the Americas, how we can start with that internal collaboration. The second step is now that we are working internally within the Ministry of Health, putting together all the groups, how we can now engage those groups outside of the Ministry of Health that are related to the interventions on the root causes from the perspective of the social and environmental determinants of health. And the other thing is that, and it has been mentioned several times in this webinar, is that these interventions are not happening at the national level. At the national level, we have the regulations, protocols, guidelines, standards. But in the reality, those interventions are implemented at the local level. So without engaging the subnational authorities, and I'm not saying only health authorities, the governments at the state level, at the municipality level, is key to transfer this approach about health outcomes are the result of the governmental exercise with the communities to improve the health of the populations at the local level. So that's what we are trying to do with countries and how countries are trying to include all these perspectives on social determinants within the initiatives, roadmaps, plans, or strategies for the elimination of multiple communicable diseases, using these kind of examples for all the diseases that have been targeted for elimination.
Great. Thank you so much, Dr. Saboya. My next question is for Gina Pereira or any
La
other
siguiente
member of
pregunta.
our team. Based on your experience with the Innovate in the context of cervical cancer elimination, what are the key strategies for engaging different departments, which often work in silos, to collaboratively address challenges in disease elimination initiatives?
Ok, aquí, bueno, invito también a Gina, Isabel, Raúl, si quieren sumarse a la respuesta, quizás voy a iniciar.
Gina or Raul, if you'd like to answer, but I will start by saying that yes, the approaches that we have is different with different ways. We have to first and foremost understand what are the population that we're analyzing. Are we looking at girls, boys, adolescents? Maybe intervention there will be centered in education and awareness improvement, making them more sensitive so they do not develop these diseases. And in screening, we have different interventions along that line. We have access to screening, education, understanding what is the importance of treating and following up with the invasive lesions. So we have the different age groups. We have promotional, preventive, education, screening, treatment. What then is exactly, or what is precisely this the strategy that will help us to eliminate, as they're all will add up to elimination parameters, and these parameters are determined by the world strategy. For example, the incidence cases, those that lead to death have less than 4 per 100,000. And in order to be able to have access to that, to these levels, we have to have 90% coverage and 70% in screening and 90% in accessing to the invasive lesions. And so what are the strategies? Work with the different groups to reach these percentages of coverage and be able to to come up with the numbers that the World Health Organization is asking for us. I'd like to add to what Dr. Marina was saying. Of course, it depends on program perspective, and this is added to the international perspective. Yet, if we see this with the equity, these strategies in a first type of approach, how is a program working? What is step two? We're working in step two. We're working with intervention formulas, looking and analyzing what is the population levels that are not having access to this, and who has most limits in being able to approach these populations. So we're talking about from gender point of view. We're also talking about social stratification. However, as a complete process, we still don't have the full view, but in the redesign process, we're wanting to be able to identify what is what interventions need to be strengthened for the populations or subpopulations? What kind of approach do they need? And look at it from that very specific approach. First, we started by guiding and directing our efforts in promoting information. We are seen as a sectorial and country intervention learning. What do we have to work on? And this is why we're living this process. It is a comprehensive process, and the node is built, as Gina said, by people from the different sub-level areas. We have people coming from organizations, people working in primary health care and work in specific communities. We do understand that if we see this from a central area, we won't be able to target the regional factors, and this is why we are working with the type of focus as a strategy and looking at subpopulations if we're going to think along the lines of equity.
Thank you so much, Dr. Gina Pereira and Gina Atencia, for your answers. I have another question here from our Q&A box, and this one's directed for all the panelists, but maybe for our Chile team as well. In terms of equity in the care of people with cervical cancer, why do most treatments such as brachytherapy, radiotherapy, and certain very effective medications not exist yet? What is the plan for disadvantaged countries in achieving the fixed objectives as of now? This is a big question. It's a twofer. So I'll let anyone that wants to start come off of mute here.
Tal vez voy a cambiar al español. Vanessa, antes de que nuestros colegas del Ministerio de Salud de Chile
before the health ministry colleagues can answer how are they guaranteeing access to the different uterine cervical cancer for the different groups and vulnerable groups in Chile. That was one part, but then we also talking about the regional area. The Americas region is a region characterized by having country capacity in influencing intervention. The role is to have the technical cooperation, so we have the best practices inserted into the national programs trying to eliminate different diseases, including uterine cervical cancer. Certainly those countries that have the highest level of the structural problems or interventional problems, well, we're working with them to help them accelerate. We're working with the program of the chronic diseases, and we include the uterine cervical cancer to be able to accelerate and adopt interventions such as screening, the vaccines, and treatment. If it depends on the structure and the capacity. This is seen from the PAHO point of view, but of course, we're working for those countries have an access and have it in a sustainable form, understanding that country capacity is different. It doesn't depend entirely or wholly on PAHO. However, we are working with countries to accelerate uterine cervical cancer, one of the 30 types of diseases. But maybe Gina, you could talk about what type of access is happening in Chile. Thank you, Dr. Saboya. In Chile, since 2004, we have a guarantee regime. What does this mean? It means that there is, by law, a specific interventions for the screening, treatment, and I understand your question is directed that way. With uterine cervical cancer, yes, treatment is guaranteed with different levels of treatments. For example, with radiotherapy or other forms of therapy, which means having financial protection quality along several lines. And this law is updated every 3 years. The bill likewise is updated every 3 years. And we as a team have to look at the problems. What are the interventions and what are the actions taking place and analyze and then it depends on the budget availability and we will provide improvements. Now, amending this law, we had in order to amend this law, we have sub-steps, evaluating interventions, understanding which are included and which are not. Now, in summary, yes, there is access. It's included in this law guaranteeing access. This is updated according to the evidence that we have and according to budget availability.
Thank you so much, Dr. Pereira and Dr. Saboya, for those answers. I think this one, our next one that I have here is specifically for the Chile team. I believe it's actually specifically for Gina Atencia. Why do you recommend doing this redesign process, understanding that it involves a significant investment of time? Over to you.
Perfecto, una excelente pregunta porque
That's a great question, thank you. We know that overall cancer is a multifactorial type of disease. Sometimes it does involve genetic factors, but it is specifically uterine cervical cancer. It's affecting the population that don't have access. And then we need to look at the access. Why at the causes? Why don't they have access? Yes, most of the highest level of mortality happens in those countries that have middle and low type of socioeconomic level. So this isn't just out of nowhere. That we do have important social determinants which are hindering access, and they are not being able to receive screening, vaccinations, and treatment. Although we understand this is in addition to the type of work that we have, both national and regional type of work, we understand that it's something that we owe to the population. We have to go after these populations that they are not being able to be reached. We have to take care of them. And unfortunately, we didn't reach there because we didn't look at these social factors or access problems that have to do with inequality that are completely unfair and they are avoidable.
Thank you, Dr. Pereira. I think on your next question. So first of all, I actually just want to say thank you so much for the webinar.
Gracias a la doctora Pereira. Bueno, quiero darles primero las gracias.
And I would like to also say thank you for our webinar. Sorry about that, webinar participants for such an engaging participation. We've got a lot of questions coming our way. We will try to get to all of them, but I will say now that we will try also, if we don't get to all of them, we will share a list of questions and responses later on after our webinar. Our next question is for Dr. Saboya. What specific actions related to social determinants does the initiative plan to undertake to eliminate open defecation by 2030? For example, will there be investments in sanitation infrastructure, or will there be access to clean drinking water and sewage systems programs?
Thank you, Vanessa. Gracias por una importante pregunta. Justo
Well,
el
thank you
tema
very much for this very important question. Being able to eliminate this will help us eliminate this fine line that we have between the responsibilities that we have.
que estamos haciendo con los varios países para poner juntas sus hojas de ruta, planes.
We're working with the various countries to put together the roadmaps for elimination and strategies. It's almost always a surprise for the different health teams to look at the number of people that practice open air outdoor defecation, and that a surprise also goes hand in hand with something that we hadn't considered, which is a problem that we should look at and we should have considered it. However, open air defecation is an issue that is related to several of the communicable diseases that are included as part of the elimination strategy or initiative, not only for tropical neglected diseases, but also some of those are related to disease transmission by contamination, contamination in water, soil, food. So the first exercise is to recognize, along with the countries, see who is having the problem. And the second question that they ask, once they're surprised by the response, they want to know where those people are that are defecating outside, outdoors. So we go to a needs assessment. We need to see where those people are. Where are those people that are affected by a certain disease or are practicing open air defecation, and why does this practice persist? And then we have to involve the other sectors that are, have to do with this issue at the subnational level. So it doesn't mean that the health sector has to be responsible for all the investments in water, potable water, or sanitary systems or sewer systems. However, we need to work to identify which sectors have to intervene, work with the local governments to decide which areas are affected by this, and work. I have worked personally, for instance, in indigenous populations that are affected by multiple diseases. And when you ask them or you tell them that there is defecation in open air defecation, the immediate reaction of a local government is let's install latrines without any involvement from the community, so that they understand, first of all, whether this is a problem for them, because they see this as a natural activities. Open air defecation is something that they consider to be natural. And if it is a problem, what is the solution? I have seen latrines or even bathrooms that are used as places where you plant seeds or you plant, because culturally the intervention has not been accepted. This is an intervention that was implemented by external agents. They believe it was a solution, but it's not. So we're working with the countries. First of all, we need to identify that open air defecation is a problem. Second of all, where are those people? And in the third place, what are the interventions? How can you get the communities involved so that you can implement activities that are appropriate? And that has to be done hand in hand with the groups affected by this. Open air defecation is something that happens in a separate department in the organization, and we're working with them to see what kind of instruments, what kind of tools we already have. We need to work with the countries to identify what are the actions that are necessary to reduce this practice. And just like any other question that has to do with intersectoral strategies, it's not just to build infrastructure. It is possible that you're going to need the infrastructure, but you need to identify where they are, how you're going to implement the intervention, and how you're going to work with the other sectors that have to work on it.
Thank you, Dr. Saboya, for that answer. Our next question, I believe it's for Dr. Oria Olmozabal and Dr. Gina Pereira. or the Chile team as a whole, do you agree to improve health outcomes in the most vulnerable populations? It is important to work on technical guidelines for addressing health determinants, not only to be used by the health sector, but also to be used by other sectors such as education, housing, etc. For example, what do you think about that?
No sé si quieren, bueno, puedo decir algo yo y después el equipo de Chile, ¿no?
I can say something first and then we can move on to the Chile team. Well, without any doubts, when you're talking about social determinants of health or how to approach those determinants, this is not something that you can do just from the health sector, but you have to have the intervention of the other sectors as well, and other sectors in the public arena, and other than the public sector as well, other private sectors. And therefore, one of the purposes of this is to work, focus on intersectoral work. And this is not an issue that occurs outside of the health sector only. There is a health sector role that we have to play, not necessarily leading the process, but being part of the other public policies that impact health. Beyond the naming other sectors outside of the health sector, approaching social determinants of health is what they do, but also it's a specific area in which they're already working. So therefore, are we able to build on these collaborations, get to common goals that can be approached in terms of the interventions, design of the interventions, the governance structure, and even the things like cultural terms? The institutions are different. So we have this common goal, and we have to work together to approach social determinants of health. But there is intersectorial work that has as a common goal to approach this problem that we see as a priority, the different sector cities as a priority, and also we are looking for equity. Is one of our common goals. And you have to always look at social determinants of health, and it has to be work that has to be done in collaboration. And that is my personal view. Thank you.
Anyone from the Chile team want to add to that answer as well?
Sí, bueno, también gracias por la pregunta. La verdad es que
Thank you for the question. In our team, we have worked on this. This is very important. We need to consider it within our work, the intersectoriality. We need to work jointly, mainly with education. Talking about the importance of talking, for instance, about risk factors, about adoption of preventive or protective behaviors at certain ages. For instance, BPH vaccination is an opportunity to talk to our children about sexual conduct, sexual behavior that implies a high risk, for instance, the human papillomavirus, and discuss how it works and its persistence and its presence in disease later on in life. So sometimes we have to work like beyond their own boundaries and go outside of our boundaries and work with education, work with the Ministry of Gender Equity and Gender, and work with the Ministry of Work. Many women work. We have long days of work. So for instance, for self-care, we have no time for self-care. Many times women have like a double or triple shift because we have to do the work and we have to do domestic work at the same time. So I think that if you look at work and you look at education and you look at the conditions in which people live, it's really relevant so that you can consider or redesign a program.
Thank you so much, Dr. Pereira, Dr. Olmozabal. In fact, thank you so much for all of our panelists and speakers today. And thank you all for sending your questions through our Q&A box. I do want to reiterate that we won't be able to get to all of your questions right now, but your questions will be answered. We will send a document to everyone that participated with the questions and answers that have come up from this webinar. So thank you so much. We are unfortunately coming to an end of our discussion, but before that, I would also like to invite Dr. Marta Saboya back to share some closing remarks, some reflections of today's discussions, reinforcing key messages and suggesting some specific actions that we can all take forward. Dr. Saboya, the floor is yours.
Thank you, Vanessa. Thank you very much. And thank you all the panelists, our colleagues from the Ministry of Health of Chile, my colleagues from the Social and Environmental Determinants of Health and Equity at the Pan American Health Organization for your kindness in sharing with us the tools, the exercises that you are carrying out in the countries to advance on the implementation of approaches from the social determinants and equity on health to accelerate the elimination of diseases. There are several key points that have been highlighted today. The first one is that we understand that we are not going to achieve the elimination goals and sustain them if we don't include the approaches and address the social determinants of health to improve the living of the populations and millions across the Americas that are affected for multiple diseases that have been included in the elimination initiative in the region of the Americas. The other component is that even though it is difficult and takes time to work with others within the Ministries of Health and outside of the Ministries of Health, it is key to have strategies that are tailored to the needs of the populations and communities and that can be implemented in an integrated and comprehensive way in conjunction with the engagement of the communities. For us, it's critical to understand that the Elimination Initiative is an opportunity to synergize efforts, collaborations, not only with governments, also with partners, stakeholders, donors, and communities to advance on the elimination of diseases. So it's very interesting to see how the different countries have these approaches under the Elimination Initiative. And I think that if we can put those additional lenses on top of the programs that are working very hard for the elimination of communicable diseases, I am convinced that we can accelerate the efforts and sustain them and improve the lives of millions of people across the region. And probably if we can replicate this in other regions, the benefits can be expanded. I want to thank Core NTD for the opportunity to have this webinar on the approaches on social determinants of health for the elimination of communicable diseases, and our partners that have been collaborating with Core NTD, USAID, and Bill and Melinda Gates for the support for having this series of webinars in which we now have had the opportunity to have at least 2 under the Elimination Initiative. To all the participants, thank you for your time, for sharing your thoughts and the questions that are very interesting. It's not an easy topic, but it's a topic that we need to work on together to accelerate the efforts for the elimination of diseases. So Vanessa, back to you.
Thank you, Dr. Saboya. Thank you for those reflections, emphasizing the actionable steps that we can all take from today's discussions. Again, as we wrap up, I just want to also say, as Dr. Saboya said, thank you for all of our speakers for your invaluable insight. Thank you for all of our colleagues in PAHO, Core NTD, MYT that have made this webinar possible. And thank you for you attending today and staying with us for this whole session. This webinar has underscored the importance of addressing social determinants as part of the comprehensive disease elimination efforts. On behalf of PAHO, Core NTD, and all our partners, thank you for joining us once again. And I would also like to thank USAID and Bill and Melinda Gates Foundation, who are our sponsors for the Core NTD Research Links webinar series. Have a great rest of your day and goodbye. Thank you.